That's the most important principle of all the things, of course. There are a number of things I want to show you, but what was covered was recruitment of motor units. It takes time to learn because that's the most sensitive indicator of a myopathic versus neuropathic. To be able to judge the recruitment of motor units, and I'll cover that principle today a lot. I'll show you examples of abnormal, all the things which I've covered. I'll try to cover, if you have enough time and you're still awake, I'll show you each and everything, okay? Needle EMG is very critical. It's very important in certain conditions. Nerve conduction studies may not be sensitive to those disorders. For example, motor neuron disease, which is a prime example. Myopathies, you depend on EMG studies to describe what it is. Okay, so we'll cover that. So in the interest of time, I'll get to the patient, and I'll try to keep talking. Luckily, we don't require tape. Many tapes over here. We just require one tape to ground the. Can you hear me? Okay. Technically less challenging and also more interesting, trust me. Okay, so but a little painful. I'll explain to the patient. Can somebody come? Just explain to her. I'll be using a small needle to explain to some muscles. Yes, please, we'll have to take this off, please. Thank you, thank you. So my understanding is, what I heard about this young girl is that the right side of the body is relatively normal. The left side is affected, okay? I would briefly do an exam right now to see if that's correct, because I don't want to. So ask her that I'm going to check her muscle strength quickly. Okay, nobody has a hammer over here. So many neurologists sitting over here. Somebody has a hammer? Whatever hammer, I'll take any hammer. Put your hand up. Yeah, they're like this. Okay, so, yeah, okay. This one up, put up. Up hard as you can, hard, push it hard. That looks like normal strength to me for her age. Pull back. Good. Push away. Push away. Good. Go get this down. Up. Good. Squeeze. So this side seems to have normal strength. This side you can see she can barely lift her arm. So I'll check the two deltoids. One distal and one proximal muscle to see what's going on, okay? Just for demo's purpose. Don't want to stick too many needles. Up. No, you can't? Okay. No worries. Open fingers wide. And I can see the very flattening of the thenar and hypothenar muscles, wasting of the. Where's the camera? There? This one. So I'll hold this, okay? So you can see there's a finger drop over here. You see that? It's a bit flattened. This arm has got low muscle bulk. Trust me, the first dorsal interosseous muscle is thinner over here. And so this hand has got a little bit of atrophy and weakness. So it'll be a good example to see. Needle is very sensitive. It may pick up abnormalities on that side as well, but at least physically, no. Oh, same hammer, good. Okay, this hammer, we'll try to. Okay, I'm just going to check the reflexes. So it's a bit on the brisker side on this side, but definitely the reflexes are there. So unlikely to be a neuropathic process, but we can check that on this side. And this side, the reflexes are all gone. Okay. So generally, within 3 minutes, I know this side is markedly weak, proximally and distally, with some atrophy and loss of reflexes. And if you ask her, does she feel me touching her? Feel it? Close your eyes. Ask her, does she feel me touching there? And there. Same or different? Same. So it appears to be, quickly looking at exam, purely motor weakness of the left side, proximal and distal with some atrophy. It's long-standing. Can't tell me it's neuropathy versus myopathy, but considering the reflexes are absent, but sensations are intact, so it's so we'll see. Reflexes can be absent in advanced muscular myopathies. So you can't tell by, but anyway, it's a good patient to examine. I'll start from the normal side. If she can lie down, that would be great. Okay. So there are different kinds of needle electrodes. The one we use is called the concentric needle electrode. Needle, please, and a ground, please. So remember that just like nerve conduction studies, you got a recording, the 35, this one blue, 37, sorry. Yeah. So for the middle side needle, has she ever done this before? Has she had this before? You know this? So I'll be small muscle, I'll just small needle here and here. Okay? Okay. Okay. Oh, sorry. Okay. She's okay? Inshallah, I'm gentle, inshallah. Okay, inshallah. Okay, I can use the problem is, I can show you, it's a facial needle, it's very small. But the problem, it won't reflect. If you use it in the hand, it won't show you the true potentials. So for the arm, I use this middle size. And if you are a big guy, then I've got a bigger needle too. Especially keep it for big guys. So this one is a medium sized needle, okay? It's called concentric because both the recording and reference electrode is the same needle. As compared to monopolar, where the recording electrode, you have to put a reference electrode. It's the same principle. The potential recorded between the recording and the reference electrode. In the concentric needle electrode, both are in the same needle. So, so the shape of the concentric needle area is like a semicircle. It's got a smaller recording area. Monopolar has got a large area recording, so the potentials are different. So when you're assessing potentials, depends on the type of needle too. So can you make it a bit closer over here? Put it on tape because I can come here. I don't want to drop your, it's too far away. No, no, it's the whole thing needs to move. Just give me a second. Yes. I want to do both sides. I'll do both sides, one normal and just to check. Yeah. Okay, you do whatever. Whatever you feel. Please go ahead. No, that's totally fine. Totally fine. You do what you need to do, please. I just want to make sure that you guys. I never reuse these needles, okay? I never reuse the needles. There's a way to cap these needles back. You never cap it like this. Small things. You know how to cap the needle back? Medical, you better know this. You always go at the angle and then cap them. Never go otherwise you poke yourself. Always go at an angle and then cap. You'll never poke yourself. Okay? So, but never reuse them. Clean the area well. Sterile technique, okay? But if you've done enough EMGs, you'll definitely poke yourself. If you've not poked yourself, you'll definitely one day, okay? I've done it. So you get worried, oh man, I got a disease, but it happens. But try your best not to, okay? So here we go. We'll start with the deltoid. It's a proximal muscle. It's a good muscle to study. It's less painful, okay? Some muscles, again, with experience, you'll know which are more painful muscles. These muscles are extremely painful. Less painful, but still painful. These are less painful. Okay, there's certain muscles you want to. So we start the deltoid. Deltoid generally has some complex motor units, about 20%. It got generally 15% are complex motor in multiple phases, okay? Okay, good. But they can't see the screen. They can see the patient, but I want them to see the screen. Oh, that's good. Good. Good now, good. Okay. So, sorry, first ground, please. And the gel, please, and some tape, please. Thank you. That's too much. So you put a ground, typically we're doing patient lying, so you don't move ground every time. You put it at a place and then it's good for the whole limb. I usually use a place where I know that it'll be out of the way and I'm not going to go to that site. So usually at the back of the hand, where I typically, or at the back of the, yeah, they are more sticky for sure. I wish you had this in the morning, man. They are definitely more sticky for sure. I can tell even now. What's that? What? Oh, that'll be great. Thank you so much. I love that. I do it sitting always, yeah. Okay, guys, should we get started? Deltoid. Bismillah. Okay, good. Do you have some cleaning gauze? we'll shut this muscle, okay? A little bit, not that much, but that's fine, it's okay. Okay. So sound on, please, sound. So it's a combination of what you see and what you hear. EMG is a lot of hearing, The sounds are very classical. You sometimes have to look at, if you've got experience enough, you don't even have to look what you're seeing because it can, your ears will tell you. It's too high, up and down. Okay, okay. So I'll show you what I mean, okay? So your ears get trained over time to recognize fasciculation, fibrillation, CRDs, myotonia. Don't have to see them, okay? The firing pattern of each potential, I'll go over that. You can tell where the potential is coming from. Is it coming from the motor unit, axon, or from the end plate? They're totally from muscle fiber. So the original motor unit tells you the firing characteristic and amplitude, all that we'll go over in the examples. Let's go there right now. Okay, you good? So stabilize the skin. I'm holding the skin tight so it doesn't move on the needle. It reduces the pain. Okay, grip it. So if you stabilize the skin, the needle movement, okay, just one sharp movement, and you go into them. And there's a lot of artifact for some reason. I want to know why. Just making sure. Yeah, because the baseline already was to. Just give me a second. Okay, I'm in the muscle now. Is there too much artifact? Put on the 60 hertz notch filter, please. There's a lot of 60 hertz cycle going on. Notch filter right up there. There's a lot of. Am I in the right? I'm. Yep. Yesterday it was doing pretty good. There's a lot of artifact going on, and I. You want to put more gel? You want to put. There you can only see a motor unit. Just relax. I can, by just looking at hearing it, it's a motor unit. I'll tell you why, but I want to get because I want to get a smooth baseline to support the effective. Just relax. Let go. Yeah. She is stressed out, and just drop your shoulders. Relax. Yeah. Yeah. So anyway, I wanted to show you a flat baseline, resting. You can see the motor unit is not resting, and I just put it up. Yeah, still. Let go. You got to drop your hand. Good. Good. I'll pick another muscle if I can't get into this one. Let go. Drop it. Ask her to just let her drop, hand her drop. Let her hand drop. Just let it loose. No, let it. Okay. You can't. Yeah, I just want to loose. Good. So it's better relaxed, but I'm getting a lot of. What can we do to get rid of this? Usually the baseline is flat, huh? Yes, that's right. Or another ground. First, another ground. Let me give another ground before I take out the needle. Can you stop it? How do you stop it? Thank you. Just give me. I don't. Let me just put my phone away. Put phone away, huh? Yes, we can try that. Sorry. And a ground. Since you're going there, you got another ground. Let's do both. Yeah, yesterday we had a very good signal in this, but that was another room. Sorry, this was not the room. So maybe it's the room. Maybe also you have two kinds of needles. The 35. Do you have the other needle? Uh, the, no. Uh, Give me some more gel, please. Do you use the same in your EV lab over here? Different machine and whatever? Same machine and same electrode and everything? Yeah. Yeah, I think so. Maybe too much. What's that? Yes, that's the problem. Um, so grounding, yeah. So let's try another electrode and see if. But if not, we can. We got good examples I can show you. But I wanted for this patient, I also wanted to study 60. Go to 60 notch filter. It's on already on. Yeah. See. Yeah. No, no, no. The green one. Do you have the green one? What size is this? That's 50 millimeter, 35. That's 37, sorry, 37. Yeah, it's maybe. Let's see. We'll try different electrodes and different needles to see. This one. It's a disaster. No, it's not working. Too much. Better now, huh? Let's try this one. The needle poke. See. No. Is the notch filter on? What do you want to do? Yeah, it's much better. I think it's. Okay, guys, you'll have to stand up. Push against my hand. No, it's not connected. No, it's not recorded. Okay, so I think we've got the. I think it's the problem is when you connect it to the screen, whatever. But it's at least better than what I was getting before. Okay, so I think we got a better signal. I'll show you some of the basic principles. Okay. Okay, we'll put it away. Yeah. So. Still. Is the notch filter on? Something is changing. Yeah, it's very tricky. For a second it went away. Okay. No cell phone, no phone on you, anything? Phone? Nothing? Asking her, does she have a cell phone on her or anything? Herself, no phone, she's not carrying a phone. So there's a lot of electrical artifact. I'm trying to get rid of that, but you can see a 60 cycle and Okay, just give me 1 second. Yeah, so whatever you can see, we'll see where the best use of it is wasting time. I think we'll just show you what we can show you, and then I'll show you the examples there. Okay, let me. So what's the sweet speed over here? Do it 100. Oh, yeah. Yes. What is that again? Yeah, go to maybe 100 because. Okay. So what I've done is I'll see what we can do. Okay. I'll try my best, and then I'll show you. I've got some videos that I can show you. Okay. So. So she's got a motor unit which is firing. It's a little polyphasic, if I can say, but it's very hard with all those artifacts. Sorry, setting? Yeah. Yeah, when yes. What are you going to do? Sure. That, just give me a second. So there's some artifact which comes and goes. Can these lights be turned off? And the notch filter is on, and it's not recording anymore. What's the deal? See, you can try, put it on. You can use 2 grounds, or you want to try another ground? Sure. But I don't think it's a ground problem though. It didn't change with changing the ground. So we can try another ground, but show me. Something with the amplifier. So till we have, so let's talk about a motor unit. The concept it is called the size principle. Okay, what is the size principle? When I slowly activate the muscle, initially the smaller motor units come into play, and then gradually you can only increase the force by 2 ways: either by recruiting larger motor units, and secondly by increasing the firing of the motor unit. Okay, there are 2 ways. The size principle, you start activating the muscle. Initially, you increase the firing rate of the motor unit, and when it reaches a point, it recruits a second motor unit. When that reaches a point, it recruits a third motor unit. That's called the recruitment pattern, where you start with slow firing, then it goes to increased firing, and then a second motor unit is recruited. And the concept is that a normal muscle has got a particular firing frequency where a second motor unit is recruited. If it recruits the motor unit too early, as in myopathies, that's early recruitment. But if it delays and don't have many motor units, it repeatedly fires the same motor unit, 30 hertz, 40 hertz, that's reduced recruitment because it's not bringing the second motor unit. And that's a critical part of assessment of a needle EMG to look at the recruitment pattern. The typical recruitment ratio is about 5, where by the time a muscle starts firing at 10 hertz, you should have a second motor unit. So ratio 10 hertz divided by 2 is 5. By the time it starts firing at 15 hertz, you should have a third motor unit. That is critical, and I wanted to show you that. Is it working? Oh man, may guys say your praise because something is working, but it's not that good, but at least we can. So what's the 100 microphone? Yeah, this is definitely, and you can see changes with, but anyway, So I'll see what we can do. Okay, hold this wire over here, please. Hold this wire over here, please. Hold this wire over here, please. I wanted to show you that other. I wanted to show you a recruitment pattern. Okay, so you can see. Can you raise the volume? We'll work with this. Don't worry about it. Inshallah, we'll finish it. Okay. So a normal muscle is quiet. Okay, you shouldn't hear any sound. Not that high. That's good. You know that the muscle is not fully relaxed. Okay. So you are hearing a sound there. That means the patient is recruiting a motor unit. Okay, and that typically we like the patient to be fully relaxed, no sound. Okay. But that's a motor unit firing. The reason I say it's motor unit of spontaneous activity is, I can tell you why. There are few reasons. One, it's semi-rhythmic, it's not rhythmic. I'll show you an example of a spontaneous activity. It has got a semi-rhythmic, it's not a fasciculation, because fasciculation fires, boop, stops. Boop, just like when you see it, suddenly it fires and stops. It doesn't fire repeatedly, fasciculation. So hearing just semi-rhythmic pattern of a motor unit tells you it's a motor unit, as compared to a fasciculation, fibrillation, and the firing frequencies are totally different. Okay, so now either it's not recording or whatever. Anyway, so a normal muscle is quiet. Okay, and then you look at for spontaneous activities. I have not seen a spontaneous activity in this muscle so far. Okay, I've been watching it. Even in between, I haven't. So I don't see a spontaneous activity. The muscle resting is quiet, and I don't see a spontaneous activity. Okay. Let me just see if I can. I'll just try a different muscle. I'll go here. This one is, I just want to see if she relaxes this muscle bit. Good. Thank you. Now I'm in the biceps. Okay, just let go. Let go. Down. So just to tell you the screen, what is 100 microvolts per division. And the sweep speed is, what's the sweep speed? Where is the sweep speed? 100 milliseconds per division. So 10 of these divisions are 1 second. So it means that one unit, these are 20 divisions over here. If you multiply that by 5, it'll give you the firing frequency. Okay? Firing frequency of a motor unit. So it's quiet now. She's fully relaxed. So I'm just going to, so if you can, I can pick up a single motor unit. So seems like there's an early recruitment, but I'll tell you why. You can see if I can't recruit a single motor unit of muscle, the trick is you try to recruit a single motor unit, a myopathic muscle, you'll have a lot of difficulty recruiting a single motor unit. You want to assess a motor unit when the rise time is sharp. Can you increase the volume? And that you can, it's very crisp sound, okay? It's not dull thud. It's not, I'll see if I can, the volume is up? It's hard. So, just can I freeze it? Okay, just to show you these motor units over here. Okay, without. So over here, can I have a pointer or something, or is there a pointer here? Can you here? You see this? Am I covering it? Who's covering it? No, I'm covering it. It's, can you move it a little back? Angle it a bit, pull it towards you. So I just recorded some motor units from her, and I'm going to hit back. You okay? Okay, okay. Oh, no, it's not. Okay, just to show you some of the, is it working? This is not working. Is it working? This pointer? It's working? What button? Is this the button? That's, yeah. So, okay. So you got recorded multiple motor units over here. This one, you can see, I'm just going to show you some different motor units. Here, this motor unit, how do you calculate the number of phases? The number of line crosses. It crosses line once, twice, thrice, and then back. So this has got 3 phases. So 1 crossing and 2 crossing. +1. So there's 1 phase, 2 phase, and 3 phases. Up to 4 to 5 phases are normal. This one has a little more complex morphology. You can see one crossing goes up, down, up, down. So 1, 2, 3, 4, 5, +1, 6 phases. This motor unit has 6 phases, 5 + 1. The more time it crosses the line, add 1 to that, that's the number of phases. And this motor unit has a complex morphology, okay? Hard to tell by just looking at that. It's a neuropathic versus myopathic motor unit. What tells you that is the size of the motor unit, but more importantly, recruitment, okay? So there are some smaller motor units, but they are distant. The motor unit has to be the closest to the needle with a sharp. Now look at this. This is not a sharp rise time. They are dull. It goes up slowly. The motor unit you want to put for analysis has got a sharp rise time. That's closest to the needle. The closer the needle, the motor unit, the sharper the rise time. Okay. If I rotate the needle, it'll change the morphology because you get a different window. So same motor unit may complex look from one side, but depending on which in the recording field, where is the needle and orientation to that motor unit. Okay, turn on the machine, please. Okay, can you change the filter settings, please? The high frequency filter. What is the setting mode? Okay. 20 hertz. Yeah, change it to go up to, yeah. And this is what? No, go to, the low frequency. Yeah, that's good. Go further down. 2 hertz, go to 2 hertz. Okay. So better, but not the best. Just relax. Yeah. Is the notch filter on? Go to another muscle. Any other muscle. Sometimes your muscle have got a different. Any other muscle. Go to triceps. Yep. So what you hear is a lot of dull thud sounds. I am make a muscle. So she definitely has got early recruitment. I can't recruit a single motor unit. Okay, she recruits a lot of motor units with a little effort, and I'm having so she looks like having early recruitment already in that at mid. Did I reduce the gain? That's good. I have intentionally reduced the gain to show you the motor units. This is not 500 microvolt per division is not the one I use, but I just wanted to show you some recruitment, and that's what I. So if you look at, let's look at particular motor unit. Let me just find one motor unit for you. Okay, good. So now you can see this is one motor unit. You can see that? It's finding at 3 times 5 is 15. 15 hertz. At this, the firing frequency in this motor unit is, in this montage, 1, 2, 3, and multiplied by 5 is 15 hertz. Okay? At 15 hertz, they should be, you should expect not more than 3 motor units to make the ratio 5, okay? Over here, you got 1, 2, 3, 4, multiple motor units. You see that? So the ratio for 15 hertz is too low, meaning she's firing many more motor units than she's supposed to fire at 3 hertz. This is the concept of recruitment, early recruitment. She's recruiting many more motor units at this frequency. That concept is clear? So that is the hallmark of a neuropathic process. So you can see this is firing at 3 hertz, but you've got multiple motor units going on. In neuropathy, it will be totally different. This is a myopathic pattern because early recruitment. She is requiring more motor units to get the strength rather than so she's recruiting more muscle fibers, more motor units to give a little amount of strength. And that is a myopathic pattern. Okay? So so the best way to calculate that is by finding a motor unit, finding frequency of that motor unit, and then dividing with the number of motor units to see. In this, you can see many more motor units than that. Is that good? That's one concept I wanted to show you. So this is a myopathic motor unit. There's no spontaneous activity, myopathic picture. I can't comment on the phases, but I can see some small motor units, but I'm not sure because they're not close to my needle because the artifact, this motor unit, I would like to go close to this motor unit to see its size. It may be a distant motor unit, okay? So it's hard for me, unless I'm next to the motor unit, I won't be able to comment on the size. That's the thing, and I'll show you in my examples. Let's do it one more time. Let's see if we can. Okay. Okay, good. I have reduced the gain, and so you can't tell me the size at this gain, okay? So, okay, I wanted to show you insertional activity as well, if I can get it to relax a bit. Okay, can we put this machine down a little bit? We'll just put you down flat, okay, a little bit. Bismillah, Bismillah, Bismillah. Just relax. Put your hand down. Just, no. Yeah, just down, like that. Just let it drop it. Good. Excellent. Just let it loose, okay? So in the lab, we've got setting, we put it, so you can see the difference in maid just by changing her position. You see that? So it's not the best setting, but you can see that her hand is much more relaxed now, okay? Just and now, insertional activity. Doctor mentioned the insertional activity. When I move my needle, it irritates the muscle fibers. The muscle fibers fire, they get depolarized. But they only fire, should in normal person, less than 300 microseconds, meaning if this whole montage is about, how many, 600 microseconds, so this is about 20? 500, yeah, reduce the speed to 100? Yes. Okay. Now each small square is 100 milliseconds. The whole is, there are 20 divisions. Okay. So this is 100. So when I move the needle, it should not fire for more than 3-4 squares. Okay. 304 squares. That's, let me see. I'll move the needle. So you can see how long. So I'll move the needle and see if I can stop it. So here it is, okay? So this is insertional activity. And it should fire for certain duration and then stop. Normally, we expect it less than 1/3 a second. Normal insertional activity, when you move the needle, depending on your sweep speed, less than 1/3 of a second, okay? It's increased if it fires for more than 500 to or a second or whatever. So insertional activity is the early sign of muscle irritability, meaning before even spontaneous activity comes, the muscle becomes, this insertional activity increases. Sometimes you can see positive sharp waves by moving the needle or fibrillations. So insertional activity is right after my needle movement, how long does it last? Okay, we'll try one more time. You need a good baseline for that, of course, and silent, relaxed patient. Okay, so we'll try one more time, okay? So my quote, is it? So here's the insertional activity. That's my needle movement, 1, 2, 3, 4, about 400 milliseconds or so, okay? Let's try one more time. Can I just, I think this button may be metal, maybe. Sorry, excuse me, guys. You okay? So let it settle down. There's an issue with, okay. So increase the gain a little bit to about 2, no, yeah, a little bit. Yeah, it increase the artifact. That help. You go back down. Go back down and reduce the gain, yeah, please. Yeah. Unfortunately, I have to, just because the artifact, I'm limited by what I can, but usually the, the gain is not that high. But I'm just going to show you the insertion activity one more time. Yes? Yeah? Thank you so much. If that's the case, that even just I can speak louder. Here, you're absolutely right. don't want to fulfill all the thing, okay? Yes. But yes, early recruitment happens in myopathic process. Sure, sorry. Okay, guys. So what I'm going to do now, what time is it? 3. We have to rush. I wanted to show you so many things. 10 to 3. Okay. I want to go over some of the things which I covered. I want to show you some videos, okay? Some interesting videos. Yeah? Okay, I'll sit over here if you guys don't mind. Please. And some, I don't know my water where it went, but. Can you hear me? This will be without any artifact, guys. Okay, how about that? But I'm very happy we have this patient. Despite all the things, I'm still so happy that we could at least localize the problem. Huh? That's very. Oh, sorry. Okay, here we go, guys. So we'll start quickly. You already do. So, are we good to go?
Yes. Okay. Can we hear, please?
Can you hear, please? Okay.
Yes, please.
Okay. No, that's fine. When people are talking, then they're awake, isn't it? Okay. So here we go. Bismillah. Okay. So I don't need this introduction. We already covered that. Okay. I'm not going to belabor the same point. It's a qualitative assessment. You see that? There are a lot of those qualitative. There's no objective. I'm measuring this distance, how the duration. It's much visual and sound, and I'll show it to you more. It's very visual, sound, and you experience and how you do it. It's not difficult though, trust me. It's not difficult. It takes a little while. When you get to it, you can do it easily, okay? Okay. We already went over all this, insertional activity, spontaneous activity. We talked about motor unit, all these parameters, okay? So I told you about insertional activity. The insertional activity occurs when you stick a needle, sharply stick it and see how long the motor units, the muscle fiber, the motor units fire, okay? Usually, it's very fast frequency, you try, and you don't assess multiple points, 4, 5, 6, sharp needle insertions within, you don't take out the needle from the skin. You go within the same poke, you change the direction of the needle, just do a sharp and irritate the muscle. And you can get insertional activity like that. Here's an example of insertional activity. Oh no, there's no sound. Good. Let me go back. No, it's just a can you go back? There's no sound still. Oh yeah, better now. Okay. So where's the mic? Should I put it down there? No, I know, but just give me a second. Left face. No, I need a little better sound, more. Yeah, because this is very. Make the full volume. Is that the full volume? Okay. Yes, please. Because the reason I want more sound is because first to keep you awake, but also because I want to tell you how the sound matters. Otherwise, just looking at the screen is no use. And the EMG is not just looking, watching, but hearing the sound. Any better? Sorry, guys, I'm a little more particular about, but that's what it's all about. Much better, much better. Can you hear it now? Okay. So here's the insertional activity. Let me just go back to my original slide. How do you go back on this one? Okay, so let's go there. Here's the normal insertional activity. Okay, one more time. what you just saw over there was normal cell selectivity. It would fire with each needle movement and will become quiet. Okay. One more time. Okay, it's not allowing me to stop there where I want to stop. It changes the next slide. That's the problem. Let me just go back. Let's do it without the slide pattern. Let's do it this way. That's how I can easily. You can still see it. Can you see it? Okay. So what I want to show you over here was this. Look at this 100 milliseconds per division. It doesn't go past more than 1 or 2 divisions. That's if it had gone beyond 3 or 4 or 5, 6, it would have been increased in search selectivity. Got it? Now let me show you an example of that. Here's an search selectivity which is increased. That's a needle insertion right there. You see, notice that? Not only that, what you're seeing are positive sharp waves. So usually in abnormal in cell selectivity increased, you see positive sharp waves with longer duration of firing. And one more time we'll see that. I just want to show you that. Here it is. I'm going to stop here, and you see these positive sharp waves. I'm just moving my cursor. You see all the morphology, and that tells you here's a positive sharp wave. Increase in such selectivity with needle movements suggests early reinnervation. Early denervation, sorry. So before the muscle starts dying, it becomes irritable, and such selectivity becomes increased. It can be also be seen in myopathies, but in early motor neuron disease, we see that very carefully. We stick a needle and see how there's such selectivity. Okay. Sometimes you only see fasciculations. Fasciculations alone are not abnormal in motor neuron disease unless there are other findings. We all get fasciculations. You wake up are tired, your eyes twitch, that's fasciculation. So fasciculations alone are not abnormal till they are associated with other findings. This is one, increased social activity. Good? Okay, I'll move forward. Now spontaneous activity, okay? I think it was covered. End plate noise and spike. End plate is where the motor fiber enters the muscle. When you stick a needle there, because acetylcholine is repeatedly vesicles are being fused to the membrane. You're sitting there, acetylcholine is being released. And those are very small fiber potentials because of spontaneous release of acetylcholine. They come in 2 forms. One is end plate noise, the other one is, and you'll hear this very classical sound for end plate noise. You close your eyes and you'll know it. Looks like you're sitting on a beach. Close your eyes and can you mistake the sound for anything else? That's like sitting on a beach. See that? So these end plate spikes, there are few features about these end plates. They are very small. The gain is 100 microvolts over here, and they are less than 100 microvolts. So muscle fiber or end plate activity is very small because coming from single muscle fiber, as I mentioned. So end plate site hallmark is this continuous firing of very small potentials with a classical sound. That's why I wanted the sound to be higher. This again one more time. So you'll never forget the sound again. Good? That's one type of spontaneous activity which is normal. This is an end plate spike, okay, here. End plate spikes, I'll got another here. They've got a classical morphology. They've got a sharp rise time, very short duration. It's not a motor unit potential. A motor unit potential cannot be less than 5 milliseconds in duration. Cannot be, okay? Now, over here, I'll see what the gain is, but they are very short duration, you can see that. I can check the gain over here by, it's a 10-second, yeah. So you can see from here to here, it's 10 seconds. But it's barely 1 to 2, 3 milliseconds. This can't be a motor unit. Can't be a fasciculation, can't be it is a very short duration sputtering sound. If you put water in oil, have you seen it? It is, but that's the consigned. This is what the sound is. Okay, here we go again. No regular, very irregular. sputtering sound, okay? Hallmark of end, when you get the hallmark is you near needle end plate, it's very painful because you're touching the nerve sometimes. It's a painful area, patient will have a lot of pain. The moment we get into this, we move the needle away because it's a painful area, okay? Good, so far so good. Let's talk about spontaneous activity. Now, the spontaneous activity can be coming from muscle fibers or from the axon or neuron, and they've got different morphology and firing pattern. These ones come from actual muscle fibers. Fibrillation potentials, positive sharp waves, CRDs, and myotonic discharges, they come from individual muscle fibers. And their morphology will tell you when it's coming from individual muscle fiber, their shape, size, and duration will tell you it's muscle fiber. And that's how you tell, plus their firing pattern. Motor unit potential, when they fire with different, these are various fasciculations, myochemical cramps, neuromyotonic, arrestum, whatever. Anyway, let's go, I'll show you some example. Here's an example of fasciculation. They fire spontaneously. The hallmark is they look like a motor unit, but they don't fire like one because they suddenly fire and then become stop. Boop, stop. All of a sudden you get boop, they come very unexpectedly, okay? They say they're like a corn popping, you're not sure when it's going to come. Unlike motor units which are rhythmic. And not always abnormal. Fasciculation alone don't make a diagnosis of motor neuron disease, guys. Here it is. Here's the fasciculation. Hear that? They look like motor units, okay, but they're not firing like motor units. They're not rhythmic, and they come unexpectedly, suddenly, and then become quiet. Okay, they can repeat themselves after, and there are multiple fasciculation in this. Okay, one more time, just for you. So they come from different motor units, different size and shape, sometimes re-innervated motor units, so they may be very large. Fasciculation can be very large if they're re-innervation. So just like neuropathy, they can be very large to small, okay? How are we going for time? Is okay? Are we doing good? Professor, are we doing good? Okay, we are doing good? Time is good? I've got another 10 minutes to go. Okay. So we did that. Okay, here it is a positive sharp wave, okay? We talked about that. The morphology is very classical. So when you see this kind of morphology, this is a positive, initial positive, that's why it's positive, is sharp with slow return to baseline. Slow return to baseline. There's a hallmark morphology of positive sharp waves. Initial positive downward direction is sharp and then slowly returns to baseline. It's the same as fibrillation, though appears early in the innervation. So early on, you see a lot of positive sharp waves before the fibrillations come in. And that's a hallmark of denervation or muscle inflammation, necrotizing activity. And this is positive sharp waves, okay? As compared to, so, and here it is something different. And this one, you can hear it. It fires very regularly. And slowly goes away. Like a clock. You don't even see this. Nothing else fires like this except a fibrillation. This is, you just hear that sitting in another room and you know it's a fibrillation firing. Very regular like a clock. And after, if I look at for quite some time, after a minute, it's slowly firing, frequency reduce, and slowly disappear. Hallmark of fibrillation. Good? Okay. Now we go down. So this is how we grade spontaneous activity. We look at, you have to tell how severe the spontaneous activity is, okay? And it's graded from 1+ to 4+, depending if it's full, the whole screen is full of spontaneous activity, that's 4+. You can't see the baseline. And 1 is just if you single train of fibrillation of positive sharp waves, ranges from 1 to 4. So in some way you can quantify your spontaneous activity based on how how frequent it is. Okay. Here is the complex respiratory discharge. I am going fast to the complex respiratory discharge is this. You know what is ephaptic transmission? Ephaptic transmission, it happens in a number of conditions. Ephaptic transmission is, okay, when you have Bell's palsy, okay, there is reinnervation taking place. You can, when you blink the eyelid, your chin twitches, okay. Sometimes the motor units, they cross-talk with each other. Usually they are myelinated, but in conditions where they start cross-talking and motor units become linked to each other electrically and they repeatedly start firing. So one motor unit fires, the whole group fires, and by the time the potential comes to the first unit, it again depolarizes. So it keeps on going and going. Those are called CRDs. Here's a complex respiratory discharge, hallmark of chronic neuropathy. Just like machine. It's a CRD. Very regular, same group of motor units firing, periodically, regularly. The hallmark is that it stops suddenly. You'll see it in a second, it'll stop all of a sudden. So you can see multiple muscle fibers or motor units linked together. They fired in a linked pattern repeatedly at a particular frequency, very regular, and they're sudden onset and sudden stopping. Sudden onset and sudden stopping. Okay. Here we go one more time. See, it suddenly stopped. All of a sudden, it stopped. That is a hallmark of CRD. Motor units don't do that. Fibrillation, fasciculation don't. This is a hallmark of complex respiratory discharge. Very common in chronic radiculopathy, paraspinal muscles. You see them all the time. In chronic radiculopathies, they are very common in paraspinal muscles. Okay, CRDs. Many other conditions. There are certain myopathic and neuropathic also. CRDs, hallmark of chronic neurogenic activity. Okay. And they have muscle fibers who are talking to each other, cross-talking with reinnervation. Okay. What else? So complex. And let's talk about, somebody mentioned here. This one, somebody said it's a lot of fun to hear that. Here it is. Guys, do you need to look at the screen to recognize the sound? Don't look. Okay. So here it is. So it's coming from, look at what I wanted to show you. You know this is myotonic discharge for sure. Look at the composition of waveform. These are positive sharp waves. Look at this. This is coming from individual muscle fibers. And you can see they look like positive sharp waves. And they got a waxing and waning, what you can call dive bomber, but waxing and waning. In Second World War, the dive bomber would come and they'd go back up, and people get scared because there's a dive bomber coming. This was sound, and so they wax and wane in frequency, duration, and amplitude, whatever. So the waxing and waning sound. One more time for people who want to hear the game. So myotonic discharges are not always the myotonia, by the way, guys. So I have heard myotonic discharge in a lot of conditions, okay? And they are mentioned, sorry, I'm going to the wrong here. Just give me 1 second here. So they can definitely occur in myotonic discharges, myotonic conditions, myotonia, paramyotonia, whatever. But a number of myopathies do that too, okay? It's very common to see it in acid maltase. In some of the necrotizing myopathies, polymyositis, you can hear them, okay? Some of the other, and rarely with denervation you can see here very small runs of myotonic discharges, okay? So it's not, not 100% with only myotonia congenita or myotonia, but very classical sound, okay? What else? Then we go to, I'm just rushing through these slides. Here's something I wanted to show you. This was mentioned in the morning lecture, so I thought I'll show it to you. Here's what we call are group discharges. These are called myocarmic discharges, okay? Group motor units firing together, no pattern. They fire, this is not the best example, but if you think about soldiers marching, they fire just like group of soldiers marching, it sounds like, but they are group discharges, and again seen in certain conditions. I'll go there in a second. Okay, myocarmic discharges. These occur particularly when there's sometimes you get a brachial plexopathy after, particularly women, when after they have a radiation around the breast or whatever, and you can sometimes you ask a question whether radiation necrosis is a common late complication of radiation. Sometimes you get these myocarmic discharges. They tell you that this is probably a radiation induced. Okay, there's many other conditions, but again these are form of grouped discharges. Spontaneous discharges occur in grouped, like group fasciculation they call it. They don't have that firing pattern. They fire spontaneously, and they are groups. And they see in a number of conditions. I mentioned some of these. Okay. Now coming to the motor unit. Okay, we talked about this is very important. I'm just going to go it one more time, another 5 minutes. Okay. So here's a normal. Look at the firing pattern of a motor unit. I want to show you what I mentioned was semi-rhythmic. Okay, just give me a second. It's not regular, but there's a rhythm to it. Do you recognize that motor? It cannot fire slower than 4, 5, 6 hertz. Okay, anything which is firing slower, it's not a normal motor unit. There's a particular rhythm to it. Okay, one more time. It can be biphasic or triphasic. So you can recognize this by not just its shape, but hearing the firing pattern. Okay. Here's another example I show you. What do you hear there? What do you hear it? There's something I want to show you over here before telling you. Who will tell me? Okay, close your eyes, guys, and tell me what I'm trying to show you. It's a motor unit. What is that? Why? There's something feature to it, guys. Here, one more time, guys. I've told you this. Don't disappoint me. I explained to you this. One more time. Close your. I don't know what you're seeing at a motor unit. Close your eyes. Unstable. Who said that? Claps. It's an unstable motor unit, guys. It's hearing each time it fires. It's got a different firing sound, and if you look at the morphology, it's different. Now look at your open eyes at the motor unit and its sound. One more time. Unstable motor unit. Look at its morphology, what's happening to its morphology. Look at this, the same motor unit, look at its shape. You see that? It's an unstable motor unit. If you hear it, you'll know it from a distance it's unstable. Look at each time it fires, it's got a different morphology. Look at this, look at this. There's a different morphology. It's because different phases are firing, because sometimes one fiber fires, neuromuscular junction blockade, that doesn't fire. So there are different phases fire, and that shows you an unstable motor unit, okay? And that here, see this shape? It's different than, there's one phase here, there's second, third, fourth phase, turns what you call them. But if you go further down, the same motor unit, so this is a little different than this. I'm just going it slowly here. See that same motor unit firing with a different shape. So morphology, it changes, and that, look at this, these two are totally different. So the morphology change, it changes the sound of the motor unit firing. So if you hear it carefully, you will see both changing. One more time, just to. Got it? Got the concept? Early reinnervation, we look for carefully in motor neuron disease particularly. Okay. I told you about the recruitment concept. Here's, just want to run it by you one more time to get it in your system. So right now, it's firing at, so if you start over here, it's firing at about close to 10 hertz, okay? If I increase that, a second motor unit will kick in. Now you can see, now it's firing at a higher frequency and the second motor unit has kicked in, okay? And that's called normal recruitment. At a particular, if I stop it at a particular point, you can see two motor units are firing, the second one is coming, this is 20 hertz, but so by the time a motor unit fires at about 10 hertz, the second motor unit should kick in, okay? But so slowly, more units are coming in. As compared to that, look at this. We actually saw in a patient, I don't know. We just saw this. You can see how many motor units start coming out right away. It's called early recruitment. So the first has still firing, not even gone, and it's the second one comes in. The recruitment ratio, and with small amount of effort, you can see there are 4 motor units firing. The firing frequency of the motor units has not gone too high, despite it's the second motor unit has recruited third and fourth. As compared to that, look at this one. You'll know the difference right away. Trying to increase the effort. You see that? A single motor unit is firing, it can't recruit more motor. This is reduced recruitment, hallmark of neuropathic process. Firing frequency has gone to 4 times it's firing, 40 hertz. 40 hertz. The second motor unit has not come. The second motor unit come by 10 to 15 hertz, the second motor unit should come in. And look at that. So when you do the interference pattern in this patient, you'll have gaps, it won't be filling the screen. So you already have the information there, okay? So with, despite effort, it's not bringing the second motor unit. Maybe a second motor unit coming, but still for, look at this, if I increase the frequency of firing, look at this. It's now 4 times, it's about 40, it's firing 40 times per second. Despite that, the second motor unit, that's reduced recruitment, okay? Neuropathic process. I think I'm coming to the end. I want to show, what is this? What is that? Who thinks it's fibrillation? Raise your hand. Who thinks it's fasciculation? Raise your hand, guys. Come on, be brave. Nobody's testing you. How many think it's fasciculation? One more time. This is the last time. Guys. This is a pacemaker artifact in the ICU. It's an artifact. Okay? It's a pacemaker artifact, guys. In the ICU, everything is not fibrillation. It's fired regularly. It's called a pacemaker artifact. Learn to recognize this as well. In the ICU, if a patient's got a pacemaker, first of all, don't electric shock them. Secondly, recognize the pace fires very regularly. You can stand the whole day, it keep firing, unlike fibrillation will go away. If you're not sure, you wait a little minute, because fibrillation usually goes away slowly after a minute or two. You stand next to the bed all day, it will keep going on. It's not a fibrillation. I just wanted to lighten up your day. I just wanted to show you an artifact. There are a lot of artifacts, but I think any questions about all the things we covered? Good? Are you good? Thank you, guys. Okay, I think maybe some other day. I wanted to show you ages and all the stuff. There's a lot of stuff to see. You know how much you can cover in one day. What? Did we? What's the time? 3:19.
Master order at the end of the day.
No, I've got. I can show you if you want to see. I'm happy.
No, I think it's going to be very exhausting.
If you guys want to see age reflexes, I can show you age reflexes. I can show you some other things. It's your call. I'm here. If anybody interested in any other nerve or whatever, I'm happy to show you. Okay? Any other whatever.
This one. Approach twist and foot drop. Yes. خلاص هيلبس لي. You look tired?
No. I've got all of it. I can show you anything you want. What would you?
This one. Wrist and foot drop.
Oh!
Yeah.
Oh, sorry.
Wrist and foot drop. Okay.
Absolutely. Sorry, I forgot all about it. Oh, I was packing up my bag. I was about to go home. Sorry. So, okay, so I'll ask to. I'm ready. I can do anything you. I can give a lecture. I can show you whatever. I have no problem. It's we are about Azan coming.
Doctor, you can wear the mic.
telling my wife I'm all right. Just telling my wife that I'm all right. Yeah, but I'll just wait. Just let her know that. Hello? Ready to go? I need just some waters here. Okay, we're going to get her started, okay? Bismillah ar-Rahman ar-Rahim. Okay, guys, ready to go? Is this, guys, is this pointer working or this one working? Okay, this one, this one, okay. Okay, so, yeah, no, that's fine. I'm going to use it. That's fine. Thank you, thank you. It's not projecting up there. So there, Dr. Nadwan asked me to talk about a couple of common things we see in routine practice, wrist drop and foot drop. There are certain common questions we get in our lab, EMG lab, most labs get it. And so wrist or finger drop and foot drop are the one they were chosen. But of course, carpal tunnel, and there are a lot of radiculopathies, and somebody was mentioning plexopathy. And so we could cover a lot, but I'll cover two topics just to give you some idea how to sort of anatomically, clinically, and electrophysiologically distinguish those. Okay. So when you think of a possible mononeuropathy, wrist drop, you think of a radial nerve palsy, or so again, you go for the exam first, of course. We mentioned that so many times today. Make sure that you examine the patient properly. And I'll show you the common mistakes that can occur during a routine physical examination. Okay? Nothing will tell you, EMG will only help you that much. Your clinical exam is very important, particularly the neuropathy. I'll tell you why. With the EMGs, you can possibly localize the problem and have some idea whether it's axonal, how much is demyelination versus axonal. And there's some prognostication as well, how bad it is. You can tell the referring physician how bad the problem is. And if you follow them, patients in the long term, you've got a baseline you can follow. This concept has not been discussed today, and I wanted to bring it for the end of the day. Concept of abnormality surrounded by normality. You know what I mean by that? So it's not enough to see what's abnormal. It's very important to see what's normal around it. Abnormality surrounded by normality. We do that all the time in electrophysiology. We want to make sure the problem is restricted to one nerve. That's why when you see the protocols, when you do multiple muscles, multiple nerves, is to make sure it's just a wrist drop, it's just a radial neuropathy. It's not. Can you excuse me, sir? I'm getting disturbed over here, so if you can keep it low. I've been interrupted for 5 times, so please. Excuse me. Can you take the call outside, please? Thank you so much. I apologize, but I keep getting stopped. It's very hard for me. Thank you so much. And please switch off your phones if that's, I've switched off my phone. I expect you to switch off your phones. Thank you. Okay, so, so abnormality surrounded by normality. That's why when you look at protocols, you may wonder why it's a radial neuropathy, why to do median, why to do ulnar. You're expecting radial neuropathy, why you're needling another muscle which is not supplied by radial nerve. Because not only do you document the abnormality, but you surround it by normality to see it's a focal neuropathy. We do this all the time. In carpal tunnel syndrome, for example, all labs universally will check the ulnar nerve too, because they want to make sure it's a single nerve involved. Okay, is that concept clear? So when I give you protocols, that's the reason, to make sure it is one nerve, one myotome, or one whatever. Okay, good. So approach to wrist drop. First of all, wrist drop can occur all the way from spinal cord, motor neuron, nerve root C7, predominantly C7 nerve root, can be posterior cord, can be radial nerve, crutch palsy. People who use crutches, they get radial nerve palsy in the axilla. You can have the radial arm, the spinal groove, satellite palsy, we all know that, or isolated posterior interosseous neuropathy. Okay? So when you get a wrist drop, we look at all these things. And when we think about these things, we examine the patient to make sure where the problem is. Because if you know your anatomy, you can clinically localize the problem to C7 versus radial nerve easily, even plexus. Okay? And I'll go to you and tell you a scheme how to do that. I'll tell you the key muscles, which takes you a few minutes to examine to tell you where the problem is. Okay? I'll give you a clinical. Acute stroke gives you a wrist drop too. Acute stroke gives you a wrist drop. Gives you hand weakness. How do you tell it's an acute stroke? A patient wakes up in the morning in the hospital, and I've had these consults. Or when I'm a service, this patient has acute weakness of the wrist drop. Is it acute stroke? I've got it. Thank you so much. So how do you tell? Okay. I want you all to put your hand like this. Everybody. Okay. Good? Put your hand like this. Okay. Check your intraosseous strength. Try as hard as you can. Are they weak? Can you give full strength? Now do this and check your intraosseous strength. Is there a difference? First check. You examine the person in wrist drop. So whenever somebody's got a wrist drop, you put their hand like this. Because intraossea is supplied by which nerve? Intraossea is supplied by which nerve? Ulnar nerve. So if somebody got a wrist drop, you examine this patient in this position, it will be weak. You can all try it on yourself. In this position, your intraossea will be very weak. So you may think it's wrist drop, but also ulnar nerve. So it's not a radial nerve palsy. It's more than that. Same thing, the foot drop. If you examine a foot drop strength in this position, you will have difficulty examining the strength of foot drop doing eversion, inversion. You have to bring the foot in the neutral position to check its strength. Same thing for wrist drop. You want to put his hand somewhere stabilized and then check the, because the patient wrist, he can't do it himself, you have to have them hold their hand on something and then check their intraosseous strength. And that will be normal. That will tell you clinically it's still restricted to the, it's a very common, because when you're looking at the hand muscle strength, if you do it in this, check your ABB strength as well. On this, you'll have weak. So if you check your ABB strength in this, you can do it on yourself. You can't give full strength. Same for intraossei. So in a radial nerve palsy, you want to examine a patient by having hand over here and then check. And you will see that it's only the wrist drop. Good? That's an important point. Let's keep going. So here's the anatomy. I'm not going to, it's not an anatomy lecture, but I want to show you the key areas which you want to be concerned about. Here's the radial nerve coming. It's formed from C5, 6, 7, 8. There's no T1 in radial nerve, by the way. So C5, 6, 7 nerve roots they go through the plexus. The wrist drop is mainly C7. So a lesion of C7 will give you wrist drop, but also the C7 fibers then go to the trunk, and all three posterior divisions make the posterior cord. And then out of the posterior cord from the radial nerve. But remember that posterior cord also gives out the axillary nerve, which gives to your deltoid. Plus, it also gives a branch to latissimus dorsi. So, the reason I'm showing you this is that at the plexus level, a lesion would involve the axillary nerve and latissimus dorsi. So, in a patient with wrist drop, it's critical to examine their shoulder abduction. If that is weak, you know that it's not purely radial nerve. Got it? At each level, you got clues. Okay? Sensory exam in the radial nerve is limited. I'll talk about that, and we'll talk about reflexes as well. But very importantly, you want to make sure that with a patient with wrist drop, proximally, they don't have shoulder weakness, which is outside the radial nerve territory. As the radial nerve comes down, the first few branches give us the triceps. The nerves to the triceps arise before the spiral groove. So a patient who's got a radial nerve palsy in the arm, triceps are spared because the branches to them are given before the nerve enters the groove, which is right on the bone, the humerus. The bone, this is a common site of radial nerve palsy because the nerve is next to the bone over here. But before it gets there, it has already given the triceps branches. So at that level, the wrist extension is strong. As it comes down, it gives some branches before it enters the arm. The reason I'm telling you that is, it's important. The brachiodalis branch to the brachiodalis. Brachiodalis is only flexor muscle which is supplied by radial nerve. It's very critical to remember this. It's the only flexor muscle in the forearm supplied by the radial nerve. Everything extension is by radial. Finger extension, forearm extension, okay, elbow extension, all wrist extension, they're all radial. Everything is radial. But there's only one muscle in the radial nerve, which is brachiodalis. The brachiodalis flexes the arm in the mid-flexion position. If you look at your brachiodalis, it'll become activated with this flexion in the mid supinated or pronated position. That's why the brachiodalis is most active, okay? And that branch is given in the forearm. There are two branches which are given in the forearm. The nerve to the brachiodalis and the extensor carpi radialis. The reason I'm telling you is, with wrist, when I'll go over the clinical exam, they will be important, okay? And then it goes to the supinator muscle. It gets paralyzed over here because it's going through an arch, and then gives the posterior interosseous nerve, which is now purely motor. The radial sensory branch goes down right at the lower forearm. It's anatomically it can be different, but by the time it reaches forearm, it becomes purely motor, purely motor. All the sensory fibers are given, all these branches to the extensor compartment are given, plus the last branch is extensor indicis. Extensor indicis is the inside of this finger. That's the last branch of radial nerve. The reason I'm telling you this is that it is supplied a C8 muscle. It's critical in ulnar neuropathies and medial cord, because if this is involved, it's a C8 radial supplied muscle. It's differentiated from some, and that differentiated some of the ulnar neuropathies and stuff, okay, and middle cord. But anyway, most distant. So this is the anatomy you need to remember. The branches to the deltoid and latissimus dorsi, examination-wise, the triceps, it's given before it enters the groove. So tricep jerk will be intact if it's given there. Remember that, because it's already supplied. And then you come to brachiodalis and stuff, okay? Let's talk about now, with that basic anatomy, what happens. Here it is. So here are the key points. C7 nerve root level, the cord level, at the axilla, in the groove, and the posterior. We'll talk about these five, how to differentiate these two, okay? So examine-wise, anything, all this will give you a wrist drop of finger. That's common to any site. So where the site of the lesion is depends on what your examination shows. If with radial, if there is, along with lateral deviation, okay, that tells you that the branch, this branch is intact, okay. So you have probably a posterior tortious lesion because the wrist and finger drop and radial deviation means this is intact, okay. Now, this is where the brachioradialis comes in, okay. So if the brachioradialis is intact, it can be either C7 or posterior tortious neuropathy. All other sites, so either the nerve is involved over here, posterior tortious with a wrist drop, or at the C7 level, because brachioradialis is a C5-6 muscle. It's not involved in C7 radiculopathies. It's involved in radial neuropathy. You got this idea? So that's why I was showing it to you. So in a radial neuropathy, you expect this to be weak. The only places it will be preserved, it will be either the lesion is posterior tortious or C7. C7 does not affect the brachioradialis. The most common problem is either radial neuropathy versus C7 radiculopathy. Those it's unusual to get a brachial, so you have to distinguish typically between C7 versus radial in a wrist drop. And look carefully at this muscle. This will be preserved, okay. C7 affects the triceps as well as, but we'll go over there in a second. Anyway, so what about elbow flexion? I mentioned that. Sensory loss on the hand. So what's the best place to check the radial sensation? Anybody knows? Where do you check the radial sensation? Yes, your first dorsal interosseous space. Okay? So radial sensation, if there's a radial loss, sensory loss, what you get is that you get in posterior cord, all the, but not in the posterior tortious nerve. It's a pure motor. Elbow extension, you get it in C7, weakness, you get in posterior cord, but as the nerve goes down, beyond the groove, you don't get weakness for elbow extension. So in a patient with radial nerve palsy over here, the extension is preserved. So if somebody's got a wrist drop, finger drop, elbow extension is preserved, you think of radial nerve palsy at the radial nerve, at the groove, okay? And I told you, these two are key. Shoulder abduction is a C5-6 axillary. It tells you about C7 as well. So if this is weak, shoulder abduction, either it's a cord lesion, posterior cord, or a C5 radiculopathy, which is another common C5. The commonest radiculopathy in human body is C7 or S1. L5 and C5 are the next common. So C7 is because the most mobile area of the neck, so C7 radiculopathies are very common. And so to differentiate C7 versus radial, first of all, it's shoulder abduction. But remember that wrist flexion is also C7. So in a patient with wrist drop, you also want to check the flexion strength. This is outside the radial nerve territory, the wrist flexion. You got it? So if somebody is weak in wrist flexion, it's outside the radial nerve territory, it's a C7 myotome. So common thing about C7 is wrist drop and wrist flexion weakness as compared to the radial nerve, which is just wrist extension. So we carefully look at wrist flexion to differentiate it from radial. Does that make sense? I'm just trying to show you the features. And then, of course, triceps jerk, we told, this is very key, brachioradialis jerk, okay? A brachioradialis jerk or supinator jerk, we call that, right over here, it's a C5-6 jerk. It's spared in C7 radiculopathies, it's spared. So wrist flexion is affected, but brachioradialis is normal. Got it? So, based on this exam, what you did, you do nerve conductions. And here it is what the plan is. Okay? So you check the radial snap sensory responses, and they will be preserved in a radiculopathy and posterior interosseous neuropathy. They will, because PIN is purely motor. C7 and motor neuron are ruled out if the sensory responses are affected. So radial snaps are one of the easiest sensory responses to get. They are involved in all radial nerve lesions as well as posterior cord lesion. But it will be proximally at the root level or the anterior horn, or more distally, it becomes pure. So radial sensory responses are an excellent localizing feature in radial neuropathy versus radiculopathy. We look at it very carefully, we do side-to-side comparison. Okay. Also radial stimulating, there are different protocols. You can stimulate the radial nerve. You do a 3-point stimulation, you go below the elbow, you go above the elbow, and you go above the groove. Sometimes you do up to, and compare side to side. The radial CMAPs are not very localizing. Anytime you axonal involvement, right from there all the way down to the pin, if you're recording at the posterior, they'll be affected. So they're not very localizing, meaning they can be reduced in all of these places. It's the sensory responses which are much more localizing. You got this? So if you record the snap or sensory loss over here, that is much more localizing than the motor responses because they'll be weak, okay? That's why the patient has a wrist drop. The patient has a wrist drop, you got axonal loss or whatever. So, but we also check the other responses I told you. Median ulnar, making sure that they are normal. The money is in the needle. The needle will tell you localize, okay? So we check the needle supply, EMG supplied needles, and we check the muscles which are denervated, okay? So if the extensor in the cyspop, you put a needle in the EIP, if it's denervated, it doesn't localize, it tells you that around it's got C7, 8, and it will be affected in all these conditions, okay? Then you check the brachioradialis. I told you that. Brachioradialis is an excellent muscle to check in radial nerve palsies because it tells you, rules out C7 and posterior interosseous neuropathy. Excellent muscle to check. Triceps, depending on where the lesion is. If the lesion is above the groove, it will be spared. So it will be spared in, it will be affected in posterior cord or axillary lesion, but as it goes into the groove, they will be spared. In C7, the triceps can be affected because it's got somewhere C7. So it's not 100% discerning, but typically it's spared. So it will localize from nerve roots. So if you start from spinal cord to, spinal cord, posterior cord, axilla, arm, and pin, and you can have a scheme where you check different muscles. So just to make sure it's a radial neuropathy, we always check a C7 muscle, either pronatories or flexor carpi radialis, to make sure the C7 myotome is intact. So it's not, if this is involved, these muscles, it will suggest the problem is in C7 because it's now the flexor muscles are getting involved. So we always needle a muscle in the same distribution, root-wise. So C7 muscle, okay? So if this is affected, that means that the lesion is in the either the spinal root or the motor neuron. Motor neuron will give you the same findings, except that the sensation will be intact. So if you look at the motor neuron disease, you'll see that it's affected, but also the flexor muscle. So it won't happen with the motor neuron disease or nerve root that the extensor compartment is only affected. So based on your anatomy, you go to another C7 supplied common muscle in the flexor compartment to make sure it's only in the distribution radial. Are we good with that? So this is how, and here it is. Also, if you are suspected, if you think deltoid is an excellent muscle to check in wrist drop. Deltoid muscle because it's supplied by axillary. And finally, one last muscle we check is cervical paraspinals. The cervical paraspinals are affected in nerve roots and motor neuron disease. So if the cervical paraspinals are affected, the lesion is very proximal. So one of the good muscle to test for us in radiculopathies or these mononeuropathies or other is cervical or lumbosacral paraspinals, because those are the most proximal muscle you can check. If there's pathology there, you know that you're dealing with multiple nerve root or nerve root problems. Does that make sense? So bottom line is you periodically You examine the patient and then tailor your exam to do it in the radial nerve territory, looking at different muscles in the radial nerve, distal muscle, a little more proximal, and the very proximal muscle. So this will give you an idea where the radial nerve is affected. And then you make sure it's only the radial nerve, you check other muscles. Okay? And finally, these muscles, cervical pastime, just to make sure it's not a nerve root problem. Does that scheme help? Here's a nerve conduction study of a radial nerve. We have done this all day. So here's the radial C-map. Always do side-to-side comparison. As you go above the elbow, the affected side, you can see a marked drop in amplitude. This is a hallmark of a radial neuropathy. If you find a conduction block, you are golden. It tells you where the pathology is. So this is this is at the forearm, lower arm, after the groove and before the groove, the radial groove. And there you go, you get a C-map, which is reduction in amplitude, and they tell you a conduction block. But that's not the only thing I want to show you. I want to show you something else. This is very important. Despite the conduction block over here, the distal C-maps are preserved. You see that? The C-map amplitude is not reduced. Excellent prognosis. This patient will recover very fast because the axons are not involved. It's a pure conduction block. If the C-maps are distally preserved, it helps you prognosticate. You can do a needle as well, but this will tell you that based on what we've been talking about all day, the axons are preserved, it's a pure demyelinating lesion, and chances are that he'll recover pretty quickly, this patient. Good? Any question about radial neuropathy or a wrist drop before I go quickly to a foot drop? I mesmerized you, made it too complicated, made it more, what? Good? Anything. So bottom line is, guys, you need to know, and if you want to do EMG in your life, you need to know your anatomy. Okay, that's a period. You got to know that these nerves, not all branches, this, not the, has anybody seen Gray's Anatomy? Gray's Anatomy, have you seen it? When I went to med school, I used to read Gray's Anatomy. I'm just telling you. I said, crazy, I would carry in my suitcase when I would travel. Anyway, but you don't need to be a Gray's Anatomy. You just need practical anatomy, okay? What I was showing you over here is practical. I didn't want to go to the whole radial nerve telling you the whole anatomy and nerves and the branches, but key branches. How difficult it is to remember axillary nerve, which you all know that are the deltoid. And then nerve to the triceps, couple of nerves down, and that's all the radial nerve there. And the muscles which are supplied by C7 myotomes. I told you pronator teres, I tell you, and those are common muscles we can assess strength-wise. By the way, how do you check pronator teres? Check my pronator teres. Okay, what are the two main pronators in the arm? So there are two main pronators. Okay, biceps, huh? Biceps and what else? Sorry, yeah. So sorry, supinator and the supination and the biceps. They do check the supination. Okay, so biceps supinates and flexes the arm. The problem with pronator teres is that it's only active in certain positions. The best way to check pronator teres is with elbow flexed, not straight, because it does not have enough. So the muscle goes from here. If you test it, it won't. You have to have the elbow flexed. And that's what I was trying to point out. In this, there's another muscle called pronator quadratus over here, I'm not making it. That is the one which is active in pronation the pronator teres is active with the elbow flexed because it gives them access. So what I'm trying to say over here is pronator teres is a good muscle to remember in C7 radiculopathies because it should not be denervated when you put in a needle, okay? Okay, let's go to foot drop and, okay. I still use the name peroneal neuropathy. Now the name has been changed to fibular, by the way. But anyway, so the most common location is the common peroneal nerve, okay? Because right on the bone is the fibula. That's the most common. We see it all the time, foot drop due to common peroneal neuropathy. 80 to 90% of times it'll be there, okay? But the problem is it can be from many, many other locations. Sciatic neuropathy. Now there's a particular thing about sciatic. You think about it, it's a big nerve, but the peroneal component of that nerve is very superficial. Even in somebody who's got sciatic neuropathy, the peroneal component is much more involved than the tibial component. You know the peroneal, just to people, I don't need to tell them. The peroneal compartment is the main dorsiflexor, while the tibial component does the main plantar flexion of the foot. Is that good? There's some other things, but so the sciatic nerve, the way it's physically arranged at the back in the buttock, the peroneal component is much superficial, gets compressed easily. Even with sciatic neuropathy, you usually get much more peroneal involvement than tibial involvement. Although both are weak, much more for peroneal, and it can be easily be mixed up. Okay. Of course, L5 radiculopathy is common in the low L5 and S1. Of course, lumbosacral plaques not that common. Motor neuron disease, of course, and finally, just like the posterior tortious nerve, the deep peroneal nerve, the pure motor branch, deep in the calf, sometimes gets involved. And you can get a foot drop from that. Isolated foot drop, purely sensory, purely motor, and without involving the peroneal nerve does two things in the leg. It dorsiflexes and everts. The eversion compartment of the foot is also peroneal nerve. And so in deep peroneal nerve, because the branch is already given, it's only called the foot drop, not the eversion weakness, just to clarify. Okay, the most common question is this one, whether it's L5 versus peroneal neuropathy, most commonly, just like radial was C7, C5 versus common peroneal, okay? So the EMG is helpful in that. Let's quickly go next slide. So here are the sites for involvement. Of course, the L5 nerve root, the sciatic nerve. One of the things I want to show you over here, this slide is for one particular reason. The peroneal nerve supplies only one muscle in the leg, in the thigh. Short head of biceps. Somewhere, here it is. So that short head of biceps, for us EMGers, is a big help. It's a big help. Because it localizes. It helps to localize the neuropathy. If this muscle in neuropathy around the nerve here, up in the thigh, it should be preserved. So short head of biceps is the only muscle that supplies in the thigh. Okay? That's one, for us, it's very important to remember. As you go down in the leg, around the knee, this is the most common site of peroneal common neuropathy, okay? And foot drop. So, exam is rather easy for this one. I only told you about that caveat. Always examine the foot in a neutral position. You can try yourself, check your inversion in a foot in this position. If your foot is plantar flex, you can't generate much strength. You can try it on yourself. So examine the patient in a foot neutral position so you don't falsely the inversion in eversion, because this is critical. So the big toe, extensor lucis, the big toe which extends, is supplied by common peroneal nerve, but also by L5. Okay, so remember that foot drop associated with big toe extension can occur at all places. Okay, all places. But if it's a deep peroneal nerve, the foot flexion will be preserved. So if the foot dorsiflexion, only it will give you the big toe drop. So you'll have a distal drop of the big toe. If somebody comes with a toe drop, pure toe drop, and you see that sometimes, think of the people, athletes, when they exercise a lot, and they sometimes compartment syndrome. Remember compartment syndrome? Do you know about compartment syndrome? Yes. Deep peroneal nerve can get affected by that, compartment syndrome. And so you get a pure toe drop, the big drop, okay? Nothing sensory. So that's okay. Anyway, then you come to the foot dorsiflexion. The foot drop can occur from common peroneal, from the sciatic, lumbar plexus, and L5. Okay? The plantar flexion is critical. Plantar flexion, so what I typically do in my patients who come with a foot drop, 5 seconds you'll know whether it's involved. What do? Ask them to do? Walk on heels and toes. Simple as that. Ask them to walk on the heels and ask them to walk on their toes. If a patient is not able to walk on their toes, that's a problem with the foot drop. It's outside the common peroneal nerve territory. Got it? Within 3 seconds, you can tell this is isolated common peroneal nerve or further proximal, sciatic nerve. So if somebody has a floppy foot, ask them to get on their toes or walk on their toes. Simple. You'll know that this is within or outside the peroneal nerve territory, okay? So here it is. You do the, if it's plantar flexion involved, either it is sciatic or lumbar. It's S1. Plantar flexion is S1. Dorsal flexion is mainly L5. So S1 is tibial. It should not be involved. And so it also helps you between L5 and peroneal. Okay? If somebody is not able to walk on their toes, it is outside and it's both L5 and peroneal nerve territory. And it's S1 territory. Got that? It's a very useful examination. Coming to foot inversion and eversion. There's eversion, I told you, is foot going outside. It's involved in common peroneal and sciatic and lumbar. Eversion is typically S1. Most books will tell you it's S1. It's involved in common peroneal, but not in L5. Okay? Same thing for foot inversion. Foot inversion is interesting. How should I make it simple? Foot inversion, classically, we are taught that it's done by, you know what muscle does the foot inversion? What does it? Tibialis posterior. It is a sciatic tibial supplied muscle. It's a tibial supplied muscle. Classical teaching is it's not affected in foot drop. That is partially true. If you all palpate your tibialis anterior and invert your foot, you will see that it gets active. So there's a partial weakness of foot inversion as well in peroneal nerve because peroneal nerve puts the foot in a neutral position before it gets in. So even in L5 lesions, and L5 is definitely foot inversion, but peroneal nerve can be, so that does not tell you much. What tells you is basically the tibial compartment. The other thing I want to tell you is something more. L5 and peroneal. The most important test you can do in a patient with foot drop, one muscle if I ask you, or two muscles, is hip abduction. You know how to check a hip abduction? How do you check hip abduction? Yeah, that's an L5. That's an L5, gluteus medius and minimus. It's outside the peroneal nerve territory. If that is weak with a foot drop, you know the lesion is L5, not common peroneal. So again, having them walk on their heels and toes and checking their hip abduction is critical because they'll tell you whether the weakness or what the foot drop is isolated to common peroneal nerve or it's outside. Remember, you want to restrict, and this one is a key between L5 and peroneal nerve. Key. And that's a very important muscle we needle. And every time a foot drop patient comes, it's a crime not to check their gluteus medius. It's very easy to check. It's very superficial, below the hip crest. You put a needle. If it's normal, you know it's not L5. It has to be common peroneal nerve, okay? Knee flexion, I've showed you this because it helps to distinguish sciatic versus common peroneal. It's important, okay? Other thing you want to check is straight leg raise. Somebody who got a radiculopathy will, of course, you'll have pain. Knee. Have you ever checked a hamstring? You know what is a hamstring jerk? You know what's a hamstring jerk? You don't do? You have a hammer? I can't go without showing you how to. And the small one? Can somebody come over here? Anybody? Come on, man, what's the big deal? I I wish I could lie down for you.
تعالى يا احمد تعالى احمد طه تعالى
Face down. Face down. Face down. Face down. Face down. Oh, it's a very good reflection check, okay?
اطلع اطلع فوق ايوه اوكي
And you'll have to look at this hamstring there. Okay? Just relax. You're holding it.
ريلاكس ريلاكس
It's very easy to check, but you're good? You're good? Then let it loose.
شكلك افكتد نوت بريزنت
No, it's there. I can feel the contraction. You know, patients, I can feel the. So that is a hamstring tendon. Okay? It's an L5 reflex. It's an L5 reflex, and you can see it, feel it contracting. And if it, just let me see. This is more relaxed. Oh, beautiful! You've got a beautiful reflex. And it's a hamstring tendon right there. If you check that in the face forward, it contract. It's an L5 reflex. Yes, you commonly don't check it. But in this circumstance, with a foot drop, we all have this. You can easily palpate the hamstring tendon. Do it a few times, you'll learn. Okay? It's easy to do, and with a better hammer and I can't. Oh. Okay. Somebody want to feel it? Yeah. So I feel the jerk, and if you saw, you will see the contraction. This is exactly on the medial hamstring tendon. You check it's an L5 reflex. It's important to check because it's not involved in common neuropathy. It's involved in L5 radiculopathies. Okay? Called hamstring. Thank you so much. I showed you can practice and you will see. So what is the sorry what happened? Did we miss it? Okay. So just couple of slides. Okay. Here's our EMG plan for this patient. We check the coronal motor CMAP. Of course, it will be affected in all the conditions. If we check at the EDB, but remember that in foot drop, it's mandatory that you check I mentioned somewhere at tibialis anterior. So we check the CMAP over here at the small muscle that called EDB. We also check at tibialis anterior. It's very critical to check tibialis anterior muscle. Nerve-wise, conduction-wise, as well as needle-wise. The problem with EDB in the foot, which is a muscle called extensor dayton brevis, it can be abnormal in normal people. Because of wearing wear shoes and whatever, it can be atrophic. It can show normally some spontaneous activity. It can be absent. Sometimes we can't get a response on that side. EDB is not a good muscle. It's very easy to study, but the problem is it can be abnormal in normal. It has fasciculations in normal people sometimes. It has got atrophy. It's critical to check tibialis anterior. So we do the nerve conduction and needle EMG, okay? So tibial CMAP. The other problem is that also it'll save you from, it's not involved in deep peroneal, and it's not involved, I think there's a mistake, it should be plus over here, and sciatic is involved, okay? It's involved in common peroneal as well. Sural snap, sural sensory. I wish I could show you today, but anyway, it's outside the peroneal nerve territory. It's preserved in common peroneal and deep peroneal nerves. Sciatic is affected. L5, anytime you got a sensory abnormality, it's not in the nerve roots. Nerve roots spare the sensory responses because the dorsal root ganglion, axons come and it's spared. So if a sensory response is abnormal, you know the lesion is distal to the nerve root or in most 90% of cases. Superficial sensory nerve. Of course, it's involved in common peroneal, sciatic, and lumbar plexus, but not sensory-wise or deep peroneal pure motor. So we are limited by the studies we can do nerve conduction. But needle is where the money is. Okay, in peroneal neuropathy, unless you get a conduction block, the money is in the needle because it will localize your problem. Okay, so tibialis anterior I told you, which will involve at all sites. Okay, peroneus longus is a muscle which main everter of the foot. Main inverter of the foot is the peroneal, longus and brevis. They're right there, very easy to study on the lateral side of the calf. They'll be involved in common peroneal, sciatic, and lumbar plexus plus L5. So it helps to distinguish deep peroneal and common peroneal because deep peroneal, they won't be affected. The money is in the tibialis posterior. It's a very important muscle to study in foot drop because it's an L5 muscle supplied by the tibial component. If that nerve muscle shows denervation, you know that its problem is proximal to the common peroneal nerve. It's outside the common peroneal, it is L5 or sciatic. So absolutely critical to study. So you remember that you're looking at foot drop. What the tibialis posterior has to do with that? So that's why you check it. Normality, abnormality surrounded by normality. Good? So ideally, you like to see it normal in a foot drop and you know that's a common peroneal nerve lesion. Similar for, I told you, gluteus medius. If that's involved, it's much higher up. It's not sciatic, it's L5. Gluteus medius has nothing to do with sciatic nerve. It's an excellent muscle to differentiate common peroneal sciatic from L5. It's an L5 supplied muscle. Gluteal nerves come out, they're totally different. So excellent muscle to just clinically and EMG wise. And then simple paraspinals. If those are involved by needle, you know the lesion is much proximal. Unfortunately, it can't distinguish between motor neuron versus nerve root. They have similar findings on needle EMG. That's a separate, but how common, anyway. The common scenario is L5. In L5, you'll see abnormalities, but nothing nowhere else. Okay? So in a common peroneal neuropathy, if you don't find a drop over here, CMAP, if you don't find a drop of amplitude across, then you need a much more extensive. If you find a drop across the fibula, you know where the problem is. You can be a little more, you can do less muscles. But if there is no drop there and it's not localizing, it's just a reduced amplitude, then you have to go through this exercise, making sure it is the common peroneal nerve. Is that clear? So that's why the conduction blocks help a lot. Here in the arm, and they're localizing. But sometimes, if the nerve is too denervated, sometimes you don't get the CMAP is so low that you can't get a conduction block. So what are you going to do? So then you have to rely on your needle exam. And that's where this scheme comes in, which muscles to study. And there are not many muscles. There are about 5, 6, 7 muscles, but you can easily go in quickly and check their normal or abnormal. Good? I think, and then final thoughts for the day, I hope. Okay. So so you just have a clinical, whenever you go in, you have to have a plan, okay? Based on exam. Do a good exam, you can't needle 15 muscles. Based on exam, you go in, keep ruling out, think, okay, C5 muscle, L5 muscle, what's in sciatic, tibial, what is the nerve supply? And those 3, 4 muscles are the key, okay? This is another thing. If somebody comes to your foot drop, okay, this is the Adam. You'll make my day if you tell me the answer to this question, okay? Everybody awake? Okay. A patient comes to you, had a foot drop 3 days back. I've got the answer over here. I already know. If somebody who's got a foot drop 3 days comes to you, what is the key finding on the exam? The recruitment, okay? That's why I keep talking about recruitment. You won't get fibrillations, you won't get fasciculations or CMAP will be completely normal. The Valerian degeneration takes several days to come in. If you see a patient with a foot drop, and you say, oh, they get a stroke or something, I had all the time. So the thing which stroke won't do, the recruitment pattern in central region is normal. It's not reduced. If, even in acute neuropathy, if you look at the recruitment pattern, because of whatever pathology, they won't be able to recruit motor units. That's why they're weak. So the earliest finding, most labs say, call us in 3 weeks, we'll check you at 3 weeks. But sometimes Many labs would say, send the patient 3 weeks, we'll be able to tell you what the problem is. Because by that time, the innovation potential has started appearing and stuff like that. But whenever that from hospital comes to me, I never refuse it. I tell them I do a simple small study quickly because I know the abnormality is not there. I make sure it's a peripheral problem, a peripheral nerve problem, by just sticking a needle into the weak muscles. If the recruitment is reduced, I show you that pattern, you know it's a peripheral nerve. You can, eyes closed, it's not a stroke, you don't know MRIs, you don't, it's a peripheral nerve problem. The patient can't recruit more units. It only happens in peripheral nerve region. It doesn't happen in a stroke. Even they are very weak, whenever they'll recruit the normal, recruitment pattern will be normal. And that tells you a lot. So in acute neuropathies, the key finding is recruitment pattern. And if you're not sure, you say, okay, it looks like a peripheral, it's full extent. How bad it is, I can't tell you right now. Send the patient in 2 to 3 weeks, then I will tell you how bad the full drop is. But right now I can tell you it's neurogenic, just protect the nerve or whatever, physio, and then we'll see. Sometimes they have pain as well. You know it's a peripheral nerve problem. Okay? I think I'm finally done for the day.
Last question.
No, please.
Last okay, the distal muscular dystrophy.
Yes.
Sometimes it is not diagnosed easily, especially if there is very chronic denervation. Yes.
Recruitment pattern, I told you, all day. I'll tell you, see this patient, you saw this patient, right in front of your eyes.
Yes.
Fortunately, look at, I showed you there.
Yes.
Then do it. You do MRI, I can guarantee you, it's all fibrous. When I put the needle in there was no muscle. I actually got my bone. So, very thick, I told you, right? It's very thick, it's all fibrotic.
They must take care that one of the causes of wrist drop and foot drop is the distal muscular dystrophy and distal myopathy. So don't forget this.
Final question to all of you.
Oh, okay.
Patient with 1 year foot drop.
1 year.